and all continue actually for the series of the major subjects in those interested in arthroplasty. And when I am talking about the arthroplasty, I mean the knee and hip. So PJI is the most important subject, and we know the most critical complication that we face it in our routine work in this field. Actually, we talk, this is for me as a fourth lecture in knee, but this is the third lecture regarding the PJI and SSI. We I get short notes for those not attending, and they unfortunately 2 lectures, just some notes about this lecture. Our pre-prosthetic joint infection series, we start by prevention, and inshallah we will continue with diagnosis, then the treatment, and every subject apart that has many lectures. So we talked about the host risk factors and role of antibiotics in prevention of PJI. And today we'll talk the most important, very important subject to understand what is biofilm. Is always we hearing about it. And today I hope we understand the mechanism on how it works. And also if we have time, and I will continue about the intraoperative measures of antibacterial measures that to prevent PJI and SSI infection. So we talked about the factors influence the biofilms, regarding the host factor, and regarding the bacterial germ we are continuing. In the host factor, we we have in details, we talk about the nasal swab, and how it is the area where the bacteria, staph, and MRSA were colonized. And we talk about the drugs which must stop or continue, steroids, and anti-rheumatoid drugs, and anticoagulant. And then we talked about the blood analysis regarding the disease, anemia, diabetes, and malnutrition. And also we talk about the skin preparation prior to surgery. And the other lecture was about the antibiotics. And we talk what's the significance of the usage of the antibiotics and the duration, and about the patient's risk and revision. We get that we know regarding the short notes from the last lecture that within the first year of after total joint replacement, more than 95% of bacteria causing prosthetic fracture infection due to contamination from the skin flora. What is the timing of perioperative prophylaxis? We say it's the best time 1 hour before the skin incision. And how we choose and how we perform perioperative antibiotics. And we talk that we said it is, we have some criteria how to choose the antibiotic, and regarding the onset of the antibiotic prophylaxis and duration of the antibiotic. Regarding the criteria of the antibiotic, must the antibiotic have optimal action against the staph and strep, and must have extended half-life, and have fair concentration at the site of implantation, of course, with lowest risk side effect regarding the antibiotics. What is the commonest and it is famous and most important is first generation and second generation cephalosporin. And when there is sensitivity, we prefer to use vancomycin or clindamycin or teicoplanin. And regarding the onset of prophylaxis, we say it's better 30 minutes, 31 hours before start skin incision. And regarding the duration of the antibiotics prophylaxis, we say it must be continued from the start of the surgery to the last suture. What's about redosing? 2 indications. First, when the surgery is for more than 4 hours. Second, when there is blood loss more than 1 hour, 1 liter and more. Then, what is it's important is to use is short single dose with the start of the anesthesia. What's about the extended prophylaxis? It's better not to use it because it is induce drug-resistant pathogens, MRSA, and sometimes Clostridia wolschi also cause spread of these pathogens. So extended prophylaxis is not preferred, and recommendation according to the ICM, International Consensus Meeting, is to use single dose more than multiple doses. So we return back. As all the surgeons, my colleagues working in this field are interested to work in arthroplasty, he may see in his clinic, in the hospital, these pictures, these disease, these cases when coming post TKR. So this is a different stage of infection, sinus, chronic sinus, acute, and complete distortion of the knee after the infection. What we can do, not to escape from the complication, always we say, open the window and face this complication. For all my colleagues, everything starts by plan. You have trip, you check your tire, you check your petrol. So you reach safely to the end of the trip. In the total knee or arthroplasty, same thing. To reach safely without any complication, you must plan to do this. So you get avoid to high morbidity and somewhat to avoid the mortality. Okay, today we start our lecture, which is about the biofilms. Actually, it's very important to understand how bacterial biofilm formation in periprosthetic joint infection, because this will lead you to treat the infection. And at the same time, you must know how the biofilm it works and what measure you can avoid it. Actually, the history is in 17th century, where Antonie van Leeuwen described or discovered some dental plaque. But it needs 300 years to understand what is the biofilm. Actually, Bill Constant regarded him as father of biofilm because he gave a great ideas and his experience and spirit in this subject. And actually, he passed on 2012. What is the history behind this? It's actually is a traveler man, traveling area, mountains, rivers. He sits near the rivers looking for the stone. There is always, for us also, when we sit near the river, we look at stone, there is some green layer on the stone. So bacteria is in the stream or river free living. So he think, what is this? What's this green layer which happens in the stone? So to start this, his idea that discovered this is a biofilm. What is a biofilm? A biofilm is a mesh, is a slim layer, يعني طبقة, where the bacteria form it and living under it safely, it's highly protected by a small aggregation numbers and then adhesion and their D structure, like 3D structure, then speed dispersal that would be separated. And I can discuss the stages, how biofilm starts. Always starts by the bacteria. First, start by the attachment, some bacteria, then these bacteria with adhesion, then colonization and aggregation, and like become by 3D structure, then dispersion that's separated and go to another colonization form, another biofilm. These in the biofilm, how they communicate by phenomena called quorum sensation, is the way how bacteria communicate and synchronize their action to form the biofilm by two mechanisms. First, by villi, which is pili for DNA transfer as protein, or by electric conductivity. So this quorum sensation, which is the communication between these colonies bacteria by this two methods, pili and electric conductivity, which is by amino acid nanofiber, like the telephone-like communication, they are communicating. But the biofilm, it is not, it's just present in the body, it's present in the pipes, industries, water pipes and oil pipes. It's present biofilm. And there is one sample, it's happened in USA. There is one village of 10,000 where the biofilm happened in the pipe, water pipe, and get 5 by E. coli, this biofilm, and they had 5,000 sick and 7 died. So if it is, we are seeing the biofilm in the river, in the stone, so it's a part of nature. So why we are scaring about that? Scaring because biofilm impact يعني يتأثر with the dental teeth, with the drinking water, and the most important thing, which is related to our work, is with medical implants. Biofilms impact medical implants. That's why reason we scare about that. Also, biofilms, one of the causes, major barrier to wound healing, not prevent wound healing, these biofilm. So, in the new medicine and modern medicine, we are using huge amounts of synthetic implants, prosthesis, orthosis, mesh, every kind. We are using foreign body in our work. And this may lead to foreign body infection. When these biofilms come attached, this foreign body, the may cause associated with infection, which cannot treated by antibiotics. When there happen this means surgical. Just to understand the mechanism, it's actually a video, but I did it, I like the picture. When the bacteria get to the stream, it will multiply in the stream, aggregate, then go out from this way, sometimes we call bacterium, out of the circulation. When he found a surface, foreign body surface, like implant, they get stick, adhese, multiplied. There is aggregation and goes a 3D structure, colonization, multiplication, and forming the biofilm. And the bacteria is immunized, this regarding to the host or neutrophil, because when coming neutrophil, they destroy by this toxin. And after that, they separate. When separation, this means the infection is settled. Foreign body infection is caused extremely by pathogen in low number. So few numbers of pathogen may cause foreign body infection. Maybe 100 bacteria are sufficient to cause foreign body infection than PJI or SSI. If you observe, I'm talking everything regarding experiment in the biofilm, that to get more understand what is this. And when you are seeing in the surgery, we see it's a layer, which is shiny layer. When those working in the knee, they saw it in the infected case. They, one of the experiments in mouse, they bring mouse with control number and other which inject by staph to the mouse and implant tibia with titanium plate and observe the condition after 2 weeks and 6 weeks. 2 weeks and 6 weeks for the control group and infected group by pathogen. They observe clinically, if you observe this is the infected, is tired, and the other one is active. And that, the second one, clinically, the infected one is tired, the other one is active. Regarding radiologically and scanning, if you observe after 2 weeks, this is for the control group. And if you observe for the infected, there is some source of biofilm formation and osteolysis around the T-bell plate. After 6 weeks, the control group, this, nothing. If you see it's complete osteolysis and distortion of the tibial plate. This is radiologically. So we saw it clinically, radiologically. Now, in observation, control group, this is the control group. Regarding the infected, extra-articular swelling and intra-articular complete destruction, those which implanted with infection with microorganism. What's about the plate? What happened to the tibia? This is the titanium plate, which is implanted to the control group and the infected group. After 2 weeks, this is the biofilm, which is formed, and the bacteria there is within the biofilm. Always, it's a mesh, and the bacteria under it, it's quite immune and no effect of the antibiotic or the host factor immunity on the bacteria. After 6 weeks, complete destruction of the T-plate, and there is biofilm and some neutrophil, but neutrophil has no effect because they're destroyed by the toxin of the bacteria. And this, if you observe, this is the term completely destroyed, and all the mesh of the biofilm is formed about the titanium. There is short period. How we can avoid? There is very short period, which is, we cannot know what is this period where the biofilm, it is vulnerable, that we can prevent it. But in the biofilm regarding his descent, we know it's the bacteria in the biofilm is very slowly growing, first. Second, minimum inhibitory concentration is very high. So it's protected by cellular against the cellular phagocytes or macrophage. That's why it's not destroyed by antibiotics, sorry. And also cause some source of the inflammation. So it is immune against the macrophage and causes the inflammation around the implant or the site of the infection. So whenever there is a biofilm, the therapy is surgical revision. Surgery. Therapy for this is surgical intervention, but if we know the germ, we can apply antimicrotherapy, antibiotic, to ensure the success of the surgery. Additive, adjuvant therapy, but the main is surgery. What are our options? Now we get an idea how it works. What's our option to avoid or destroy biofilm formation if we're thinking without surgery? First of all, we can moderate the surface of the device, which to prevent the colonization of the bacteria, but this is not working. Second, we can disrupt biofilm. We know how it's forming. We can disrupt the biofilm by bioengineering approach, by applying bactericidal or bacteriostatic coating to the device, like different minerals, but still now it is not well successful. Okay, we can disrupt the links, but we say by quorum sensation, by PJI or the electric. We can apply some peptide so we can disrupt and interfere with the communication of the biofilm. And this is one of the study by applying special peptide, but the result is not encouraging. Other method, they apply antibody against the biofilm or when there is the germ, and apply antibody to kill it and to avoid the biofilm. But also these studies is not encouraging. They using vaccination, but also it is far away, not under hand, and it needs more experience and more experiments. What's about chemical method to deal with the biofilms? Not suitable, because most of the antiseptics, they are toxic to the tissue. So it is not convenient to use it. And the last, it's antibiotic against the bacteria and the biofilms. They say macrolides and leucosamides interfere with the biofilm formation, but little known about the mechanism of this antibiotic working. So, to summarize about this biofilm, we get by step the history of the biofilm, what is the biofilm and how it works and destroy the implant as cause infection, and what is the methods that we can to avoid. Summarize, no biofilm without bacterial colonization. So must bacteria colonize, then the biofilm, the slim layer, طبقة, and the bacteria is under it, نايم and immune. Biofilm is common bacterial style and nature. قلنا لما نروح على reverse this green layer. Biofilm formation is induced by quorum sensation connection by PJI and electric connection. Quorum sensation is based on messenger molecule and need a critical number of bacteria. We say that 100 bacteria may cause biofilm formation. Communication in mature biofilm is based on protein, DNA, and electric signaling. Approach for therapy are prevention, and always we are talking about the prevention, and interfering with the integrity of the communication in the biofilm. At the moment, antibodies for therapy and vaccination are ideas, but not available. Chemical approach is restricted, some antibiotic with unclear mechanism of action. When biofilm form, the only treatment is surgical revision, whether it is 2-stage or 1-stage, with antibiotics tailored to the germ in the biofilm. Now, we continue for the second lecture as a series of our pre-prosthetic joint infection. We are talking now intraoperative antibacterial measures, washing solution, topical antibiotic, and cement topical antibiotic controversy, antibiotic cement loaded. And what's about the controversy, where we are using it in our work. This is risk of, or SSI, risk of infection, concept and formula. It's worn by CDC, Central Disease Control for Prevention. For SSI, SSI are impacted يتأثر by the number of the microbes. هاي المعادلة احنا عرضناها قبل. By the number of the microbes that contaminate the incision during the surgery. So this is the number, and this is host related. Most surgical site infection is caused by contamination of an incision with the microbes from the patient's own skin. If you can reduce the number of the microorganisms, we can reduce the risk of the infection. The skin is containing about 1 million bacteria per square centimeter. It takes as few as 10 microbes per square to cause surgical site infection. So by this number, if we return to the equation, this number, if it is increased, there will be SSI. So whenever we can reduce this number, we can reduce SSI or PJI. But the problem of the microbe, it's present in our body in like human cell or sometimes bacteria or fungal, as a normal flora is distributed on the nose, mouth, gut, and genital system and skin. We have 37 trillion human cell and 100 trillion microbes in our body, living a normal flora. What is the origin of the pathogens in our work in PJI? Within the first year after total joint replacement, knee or hip, we say 95% of bacteria causing the PJI due to contamination of the skin flora. So the effect of the skin and the colonization. Colonization, we say it in the nasal iris we have. So Staph aureus and MRSA, high number is colonized in the nose. CDC recommend pre-operative washing the day before, and ICM, International Consensus Meeting, antiseptic washing, chlorhexidine 1 day before. As we know, the same strain of PJI, which is the commonest cause of Staph aureus, is present in the, as normal flora in the nose. And this may change by bacteremia to cause the pathogen and PJI. One of the studies by Cochrane, about 4,000 patients, 9 RCT, searched, it said mucocin alone, which is statistically significant to reduce the risk of infection, that we apply it, as we talked before, 5 days, or you can 1 hour before surgery. to the nose. And the skin, you can apply side of the chlorhexidine washing, and this will reduce the risk from 17 to about 8%. Decolonization, another research about for 8,000 patients, they saw when they do decolonization of the nose or the skin, MRSA and MSSA reduced this number, the number and risk of the infection. This is regarding colonization. What's about irrigation? Irrigation of the wound, intraoperative irrigation by ICM, by diluted betadine, advice, and CDC by aqueous iodine, and World Health Organization, saline, no evidence for saline, aqueous iodine, there is recommendation for moderate. Just half a minute.
Okay.
Wound irrigation, intraoperative wound irrigation, and we also we have a lot of time before closing the wound. We advise by irrigation, by betadine. You can apply 17 cc with 500 saline, and this iodine is preferable to be sterile, it's not open. And this is one of the studies, 15 studies, and then 10 studies. They found that providing iodine irrigation to be significantly reduce the risk of infection, and most effective when you are using nothing, those surgeons nothing using to wash or irrigate the wound, or sometimes using saline. So providing iodine with saline, reducing these by this study high risk of SSI or PJI. So cleaning of the skin, decolonization of the nose, cleaning the skin by chlorhexidine, intraoperative irrigation. This is all measure to prevent infection at the end. And that's why the trip will be safe without any complication. The other issue, what's about antibiotic loaded Smith, where we are using in the surgery when we are fixing the tibia and femur. Does it make sense to use antibiotic with the bone cement? The history belongs to Bochart on 1960s. He's working, getting risk of infection, it's about 8 to 9%. So he tried to put antibiotic on bone cement, and he used it actually and succeeded to reduce the infection and sent message to the industries who's producing bone cement and tell them in 1969, can we apply bone cement antibiotic to the bone cement? Because he used it and succeeded. This success is actually when you see the infection rate, it's about 6.5 and reduced to about 0.5 when he used antibiotic with the bone cement. But Mr. Charlie at that time sent message to him, said, my dear Bochart, nothing leaks out of stone. الحجر ما ينطلق من عند أي شيء. My dear Bochart. And this is the error misunderstood by Mr. Charlie at that time. because we have now, we know, two kinds of antibiotics. How antibiotic release from the bone cement? Either by bulk diffusion without solvent, the antibiotic will be high concentrated but slowly acting, or by surface phenomena, burst phenomena, diffusion in solvent, highly low concentration, but it's very quickly acting. How? There is research done 2000, synovial fluid, they have high percentage of antibiotics will reach within the first hour when you apply the bone cement or you fixation the prosthesis. Within the first hour, they saw highly concentration of the antibody by burst phenomena when you apply solvent with the bone cement. And they tried many antibiotics. There is some antibiotics get long period in the synovial fluid, and like vancomycin, gentamicin, and the other, no, within 1 hour. But all of them, they have this phenomena that elution of the antibiotic to the synovial fluid when you apply the fixation. So it's a preventive measure against the bacteria. The other highlighted question, how should we mix it? Especially in revision cases when there is infection. Or it's you apply in the primary, but you want, it is plain without antibiotic, and you want to apply antibiotic. Actually, you have two methods to apply. In bone cement, we have the polymer and monomer. What we do, if you have, especially in revision and septic, you open the antibiotics, which is tailored to the germ, or mostly maybe vancomycin, but it's important to be tailored to the germ, according to the sensitivity of the germ. You open it and you apply it in the dish. Then you apply the bone cement step by step. يعني التشيز تقسمها 3 مرات or مرتين. You can mix it gradually, and you at the end you applied the solvent. And by this, at the end you apply to the solvent and mix it and become like bone cement. This is how to mix it. Okay, the other question is manually or vacuum mixing. Actually, vacuum mixing is most and better than manual mixing. And we tried many times to bring it by MOH. This is why manual mixing is less effective than vacuum mixing, because it orients pores, ثقوب يصير فراغات, bubbles. But vacuum mixing, it's homogeneous distribution. There is no bubble in it, and there is no pores. What type of cement? The famous is Palacos with the gentamicin. Actually, at time Bochart, first when he used it as 16 erythromycin used, and lastly get to the gentamicin. So, according, there is Palacos, Simplex, multiple types of antibiotics, but the most important is to be tailored to the germ. And the cement must be very homogeneous distribution of the powder bone cement with the antibiotic. It's better than to avoid these pores, because it causes cracks at the future and one of the causes of loosening of the implant. If you look to this, this is manual and this is by vacuum. This is homogeneous, and this, you see these white spots, there is holes, and this is the cause of the cracks in the future. Also, for the manual mixing, regarding comparison to vacuum mixing, there is bending stress of antibiotic loading bone cement is higher than in the hand mixing. So these two characters is preferable to go to synthetic vacuum more than by hand mixing. The other question, what is the side effect? We are okay. We are using, it's good, antibiotic loaded with the bone cement. There is side effect, yes. Two type, especially if you are gentamicin, vancomycin, we have two side effects. We know ototoxicity and nephrotoxicity. And regarding the industry, all of them making the percentage of these antibiotics less than toxicity for the renal or ototoxicity level. But because these antibiotics is going to the synovial fluid, going to the tissue, synovial, and to the plasma, so those patients which has something renal problem, you must check this antibody before going to apply bone cement, and better to avoid and use bone cement without antibiotics. And this is one of the studies of antibody-loaded bone cement, 20 patient, concentration of vancomycin and gentamicin in plasma and urine and wound exudate, that they do the experiment and measure it from the urine, from the plasma, and from the wound exudate. All the experiment showed that it is below the critical level or dangerous level. What type of antibiotics? It's according to the industry and according to the germ you have sensitivity. And like that, ampicillin for enterococci, meropenem to this organism. If you have fungi, amphotericin. So it's tailored. You can mix antibiotic with the bone cement according to the germ you have, even for the fungi. Now, we are talking about the antibiotic and we are using. There is evidence regarding using of antibiotic loaded with bone cement. There is about this, you can or you must use it or will not use it. Always we are talking about international consensus meeting and related to, and we're talking about document and research. Norwegian registration showed that antibiotic reduce the risk of infection. And if you see this, one of the literature, that in one stage revision, antibiotic loaded cement is 80% success. The other, it's without antibiotic, is about 60. In two stage, it is 91. They're using bone cement with antibiotic. The other is 82 without antibiotic, bone cement without it. So the antibiotic is reducing the risk of PJI or SSI. Another research also proved that antibiotics reducing the risk of infection. Registry from the UK and French, all of them showed that there is effect or benefit from using antibiotic with bone cement. Norwegian also, they showed, I'm showing the literatures which document or support the using of antibiotic with bone cement in UK also. So in this field or this part, there is many literatures, tens, hundreds, that advise or recommend using of antibiotic with the bone cement. but in other side, there is none. So one question in ICM is highlighted: is there sufficient evidence to support the use antibiotic loading cement in primary TKR or total THA to reduce the risk of SSI? And this is by scientists. There is a question: is there is evidence to support this idea? Because actually, this is for the companies. The companies, if you cost effective, that's why they are searching whether we use antibiotic or not using. So there is also literatures. Some of them, no evidence exists. No evidence. I am talking now to the evidence. Exists, demonstrate that use antibiotic loaded cement reduce incidence of SSI PJI. No evidence. New Zealand registry. National Journal in UK also there is literature, no evidence. Other literatures, these all are the literature. There is no evidence that you are mandatory to use antibiotic. So, that's why in Australia that the registration also showed there is no evidence to use. It's mandatory to use antibiotic with bone cement. So actually this question, it's highly highlighted and discussed in Philadelphia in 2018. And this is, if you see it, Perwizi and this, and me and my colleague, نتمنى له الشفاء, Dr. Mohammed Saeed, we discuss in this question, discussed hours and so many interference by the doctors because they are not satisfied that to use antibiotic with bone cement. So the recommendation was in the first day, they disagree about 89, disagree about usage of antibiotic with the bone cement. So after discussion, they highlighted another question. Is there a rule for the use of antibiotic impregnated cement in primary? We are typing in primary now. Total joint arthroplasty. Also this, 3 scientists worked in this. What is the recommendation? The recommendation, they said, antibiotic impregnated cement may be used during primary. So in your primary total joint arthroplasty, whether hip and knee, you can use without antibiotic or with antibiotic. And this is not because to reduce the risk of the infection, but taking in consideration the cost effective and adverse effect of the antibiotics, that the patient may have renal some disease, you can avoid antibiotics with bone cement. And by this, when the literature, when we get voting, now they agree about 98%. That's why in primary total knee replacement, you can use bone cement without antibiotics. Revision, this is another matter. When there is germ, you can mix it. But in primary, you can use it and there is no difference. Lastly, I show always cases, one case. This is also a patient is military. Colonels present us with sinus discharge. He actually did the surgery outside the Iraq with the sinus. And actually, they did for him spacer, fixed spacer. I remove it and apply mobile spacer. for him. And this is the revision which done. Actually, I am showing this just, we talked last lecture about the mobile spacer. Just I am saying, sure, look, mobile space, the benefit, if it's video, look, the patient is moving. Patient is moving and without crutches, without any tripod. This means mobile spacer, and this is the second mobile spacer. The benefit of the mobile spacer that the patient may be independent and can work this honey period, which is 3 months, 3 months period till we are doing the second stage. If you applied fixed spacer, he cannot move. It will be in the plaster for 3 months and will get stiffness and may be difficult. For the second stage, we must do tubercular osteotomy. That's I am showing. Look, this is second spacer mobile and with the complete weight bearing. My next lecture, I hope, will be about wound closure and what's the measures to avoid PJI SSI. Thank you very much.
Thank you very much, sir, about this wonderful, wonderful lecture about the biofilm and the antibiotic. And I think I have many, many questions for you. So at first question from Dr. Zaidad. How long does it take for the biofilm to be formed?
Yes. Actually, the biofilm formation, it is the critical period where we highlighted this is acute, this is chronic. That's why I say there is no line, no period between acute and chronic. It takes 3 weeks to be from 3 to 4 weeks. That is, they are saying it is acute infection because the biofilm life cycle is regarding, we say, attachment, adhesion, aggregation, and collection, 3D structure, and dispersal لمن ينفصل عنه. So it takes 3 to 4 months to form. And when it is formed, it is surgical. Whether the acute, we change poly and dia, we do it, or when you pass 6 weeks, it's going to 2-stage. So 3 to 4 weeks is the period of the biofilm formation, maturation.
Okay. So another question from Dr. Ahmed Al-Shamari, sorry. Is biofilm differ from bacteria like staph from other like Pseudomonas regarding treatment, whether to use antibiotic alone or with surgical intervention?
Biofilm, we said there is no biofilm without bacteria. Bacteria, sure, they will form biofilm, يسوي طبقة, and he's sleeping under the biofilm. So bacteria swarm the biofilm, المش, الفيلم, الطبقة, and he is under it, immune himself against phagocytosis and the host, and the antibiotics, لما نقول antibioma. So regarding the question, staph or other microorganism, what is the different is according to the sensitivity to the antibiotics, but yes, it is the same. Why are we talking about staph and MERS? Because the staph is the commonest, and I am telling you my experience. It's about 80 to 90% it is staph aureus, and that's what is present in the nose and skin flora. That's why sure, preventive measure is important. So most, and I have 2 cases fungi. We use amphotericin.
Well, I think, sir, also the type of bacteria is very important, especially in staph and MRSA, because the high versatility of bacteria, the higher formation of biofilm. And actually, I think in one of the studies in the ICM, they suggested that the bacterial motility has a higher risk for formation of the biofilm, especially when there is a little little motility, a little versatility. It may cause biofilm, but later. like an chronic infection, and C. perfringens. They suggested the type of microorganisms.
Correct, yes.
Okay, another question is that gentamicin versus tobramycin versus vancomycin bone cement. Which one is better in arthroplasty regarding the infection according to your experience?
Gentamicin, Palacos. Gentamicin is most, yes, and vancomycin for the revision.
Yes, of course.
Gentamicin, because as we said, within 1 hour, the synovial fluid will be loaded by antibiotic by gentamicin. Within 1 hour, synovial fluid that's what we wanted. This is for the prevention, but for the revision, we are using vancomycin. But
Vancomycin, yes.
for the revision, please go to the germ and sensitivity when you do aspiration and you know the germ, which type of antibiotic, go to use it. Mix it with the punishment.
Culture-based antibiotics, yes. So another question from Dr. Abdullah Al-Ani. Does these antibiotics act locally only, or they are as a systemic effect and need to be metabolized and activated?
Look, this when we apply the punishment, this is elution and going to the synovial fluid. And where is the, if there is germ, they will be tackled and killed. It is not work by systemic. So in cases of infection, I am talking now in the infection, you apply by antibodies, loaded cement, and systemic. So you not depend on systemic effect by local effect of the punishment. So because you have the germ and you have the sensitivity, you give him for 6 weeks according to the germ antibiotics systemically, and locally you depend on the punishment.
Okay, thank you, sir. Another question is that from iPhone. Okay, thank you very much for this wonderful lecture. Does the biofilm can be diagnosed radiographically to be sure for its formation, or it only depends on the timing of infection? And does any bacteria may form biofilm or only sometimes, some types?
ما فهمت السؤال شنو العفو؟
السؤال يعني ده يقول انه احنا نقدر نسوي can we diagnose the biofilm radiographically before the surgery?
Biofilm mean infection. Infection needs diagnosis, and I will talk about the diagnosis. It's diagnosis. It is not we diagnose the biofilm. We can diagnose the infection.
The infection, yes.
Infection. So how we diagnose it, I will talk about what is the markers, serum markers, local synovial markers for that. But one thing, biofilm, those working in this subject, in infection, and my colleague, they saw, it is like shiny layer. That's why when I incise them in the revision primary, when I'm working in the gutters, medial or lateral or the femur tibia, this layer, I take it like slices and send it to the culture and sensitivity because bacteria is present here under this mesh. يعني مرة واحدة إذا تشوفوه ما تنسون البايوفيلم. ونفس the green layer الستون اللي قلنا عن النهر on the river, this green layer mesh هو نفسه بايوفيلم بس هذاك biological without and but when it is in the body causing infection. فهسه حتى لما توقف على النهر لما تشوف هذا تعرف شنو. Yes, and diagnosis, I will tell you in details how you diagnose the biofilm. But whenever there's biofilm, this is infection, no antibiotics. They're surgical.
No antibiotics.
Yes.
Thank you, sir. Another question from Dr. Hussein Zorfi. Duration of action of the antibiotic-loaded polymethyl methacrylate or antibiotic-loaded cement.
Action of the antibiotic?
Yeah, duration.
Yes, according to the type of the antibiotics. Yes, I say, and gentamicin, 1 hour.
1 hour, yes.
But other topramycin, it's continue for more time, 2 weeks maybe, according to the antibiotics.
Actually, Dr. Hussein, the most important is that when you load an antibiotic with a cement, you have to be sure to raise the MIC, which means that the minimal concentration of the antibiotic inside. Yeah, inhibitory concentration. Okay, Dr. Amar Al-Qudsi. Dr. Mahmoud Shihab, in your practice, what method you prefer to wash the field? Wash the field?
Betadine, diluted betadine. I'm using diluted betadine. But I think there's some time if you use too much and by slow pressure of the lavage, 5 Pascal, you may get seroma. This is not infection. This is a seroma. But you can, before closing, and you can use 4 liter as little amount of betadine diluted with the saline. So diluted betadine I use. But this betadine, please, not opened. It is sterile. يعني من البطل تطلعها مو مستعمل.
تمام. هو هم يقصد على الفيلد. If we are going to open like a total knee or total hip inside the field, we can do betadine also.
Yeah, I am no. Yeah. What I am talking, irrigation intraoperatively, the wound.
Yes.
قلنا last lecture for the skin, provide iodine with alcohol. The skin.
Provide iodine with alcohol, yes.
The skin. Intraoperatively, iodine with saline, diluted iodine.
Yes, sir.
By lavage.
Yes, thank you. Now he is asking about explain the way you mix the betadine with saline and whether to wash manually or with washing device. He just answered that. Thank you, Dr. Mahmoud Shihab. Dr. Ahmed, he is asking, what is the dose can be mixed with the cement without affecting cement stability? Dose of antibiotic.
خليها ببالك 21 يعني 1 gram 1 gram antibiotic to 40 gram of powder. 40. Our it is 40, so it's 2 gram, not more than 2 gram. You can use less than it, but not than this because of the toxicity. We talk about it. So the principle 1 to 20 powder, according to how many powder have.
20.
Yes, this is, you can mix it.
Yes. So another question is that does any bacteria may form biofilm or only sometimes? We answered that previously. We said that the bacterial versatility and motility, and most commonly the MRSA and Staph aureus itself, most commonly forming biofilm. The other question from Dr. Bashar, regarding the betadine diluted solution, do we have to use a sterile betadine or that we use for scrubbing?
Dr. Bashar, ICM, reference ICM, they say it's sterile. They used one, its effect is less, and sometimes you don't know where it is used, and maybe like saline without any effect. And as we say, 17 cc to 500 saline. This is the dose. And it's better to be sterile, not opened.
Yeah, sealed one.
Yes.
Okay, another question from Dr. I don't know his name. Is there a relationship or not between the bacterial adhesion power and type of implant, like polyphenene, titanium, stainless steel?
We talk about if you bioengineering coating, one of the methods to avoid biofilm formation. If you go to the second step is how we interfere with the biofilm formation by bioengineering disruption. That is why by coating, by bactericidal or bacteriostatic. That's why قسم يستعمل titanium, steel. These measures is different, and that's why some causes the bacteria to colonize, some of them for decolonization. When we are talking about bioengineering coating, whether plate or the implant, the method of the coating is prevent decolonization. And the minerals is different. The steel مو مثل التيتانيوم. يعني مو مثل other subject or platinum or zircon. Yes, there is different method, and there is some of causing colonization, some not.
Of course, especially the bearing surface also.
Yeah.
I think the doctor suggested the coated. And yes, the bearing surface, like for example, in metal on metal hip replacement, they have higher infection rate than polyethylene metal on polyethylene. Yeah. We noticed using another suggestion by Dr. Bashar. We noticed using betadine cause seroma in the surgical incision.
Yes, that's why I talked about that seroma. Actually, in the knee is less because maybe impacted places seroma, but it's in the hip is more. Yes.
Yes, of course. Okay, another question here. Dr. Ali Diya, how can solution the problem? How can we solve the problem when the multi-drug resistance during multiple surgery for resistance infection? You mean that, doctor, there is a multi-drug resistance in multiple surgeries?
We talk about when there is multiple المحاضرة السابقة multiple resistance whether it is positive or negative. فقلنا إذا positive إذا multiple organ resistance go to vancomycin. If it is negative go to myronium. This will act against broad spectrum. بالICM طرحنا هذا lecture. The last lecture, this is one of question is highlighted when there is multiple organs resistance. It's positive, the organism go to vancomycin. If it is negative, use myronium and mix it with antibiotic. And you can give it systemic.
Yes, another question is that any differences between using pulsatile lavage in regard of direct wash without it?
Lavage is have 5 Pascal, 10 Pascal, 20 Pascal. For the primaries, it's better to go to 10 Pascal. For the revision is for 20 Pascal because the infection is, you may think it is somewhere hidden, somewhere in the gutters. So by your pressure, you can mobilize the infection from everywhere. But by hand, by syringe, if you measure it by hand, by syringe, according to the pressure is actually less. So it's slowly acting. It needs long time. If you are going by hand syringe or by infusion, so please take long time and more fluid to
more
clean.
Copious. More copious, yes. Well, I think there are no more questions here. If there is anything happen with you, like another question, you can remind us or write it us down in the chat. I hope that you will enjoy. We are very thankful, Dr. Mahmood Shihab, about this great lecture. And today it was about the biofilm and the antibiotic use in the cement. Next lecture will be about wound closure, sir.
Yes, maybe wound closure, I will tell you. The important aim of this summary, I want to understand what's biofilm, how it's formed, and how we prevent. This term is a lot is when you are reading, you pass it and you know what is the biofilm.
Yes.
But secondly, I hope this be in YouTube to be downloaded after the lecture.
Okay, there is another question highlighting, Dr. Ahmed. How many specimens can we take from an infected PJI? I think this is for the diagnosis. You mean the biopsy?
Yes, yes. So 5. It is 5.
Yeah.
It's better 5.
5,
Put
5 to
5
9
in the
sometimes.
agar.
Yeah.
In the agar, you have 2 types of
Mhm.
agar: blood agar and brain heart tissue. Blood agar for 5 days and brain heart tissue 15 days, because some of the bacteria is slowly growing, so it needs more time.
Slowly growing.
It's more time to be appear. So 5 agar, 5 brain heart tissue. And this is in diagnosis. We will talk about that.
We'll talk about that, inshallah.
Mm.
Okay, thank you very much, everyone. And this lecture has been recorded to you and shared in the YouTube. Thank you very much, Dr. Mahmood Shihab, and thank you very much, all of you.
Thank you very much.
Have a nice day. Thank you.
Bye-bye.